questions are for you, about you, trying to reach out to our regional colleagues and sort of give you access to the specialist team at the Freeman Hospital in short, sharp bursts. So they're here for you for 30 minutes, once a fortnight at the moment, or once every 3 weeks, Rebecca, correct me?
Every 3 weeks.
Every 3 weeks at the moment, just so we build some momentum. So please get in touch with us and let us know if there are any sort of themes, any case discussions. If you want to bring a case discussion and get some sort of some feedback from the colleagues at the Freeman Hospital, then please do that. You'd be more than welcome. So get in touch with us anytime. Rebecca will just drop the network email address into the chat box, so it's there for you. So without further ado, we'll get going, and I'll hand over to Dr. Magdalena, who's going to walk you through one of the case studies that was kindly brought to us by one of our colleagues across the region, but unfortunately she couldn't be here today. So Magda's pulled together some slides for you to share. So I will hand over to you. Thank you very much.
Mm-hmm. Thank you, Kay. So yes, I was asked to prepare this case. It's one of the most common actual scenarios, cardiac scenarios in pediatrics. So it's worth to present. It was quite a difficult case also, so we will go through everything what we met. So it was quite recent case. 7 days old baby boy, I think, born at term via normal vaginal delivery. Mom had GBS during pregnancy and was covered with IV antibiotics and discharged home. It means baby was discharged home. Admitted to a local hospital with labored breathing, grunting, pale and sleepy. So baby came to hospital in poor condition. Temperature at arrival, 33.5 degrees. Unable to pick up peripheral saturations, as peripheral cold and mottled. Heart rate was approximately 130 to 140 beats per minute. So it was first presentation in a local hospital A&E. Then initial management. Baby was treated as suspected sepsis. Was given 3 times fluid boluses, 10 milliliters per kilogram, and started on intravenous antibiotic, cefotaxime and amoxicillin, and also acyclovir as per protocol for suspected sepsis treatment. And temperature initially improved to 36, 37 degrees. And therefore, there could be attained preductal blood pressure measurement. So blood pressure preductal was 100/60 millimeters mercury, and femoral pulses couldn't be palpable, and baby looked very gray peripherally, especially in legs. Chest X-ray was performed, which showed clear lungs. X-ray was performed, I presume, mainly because it was hard working of breathing and it was like respiratory effort was increased. Cardiomegaly was present on X-ray. Abdominal X-ray did not show abnormalities. Liver was palpable, 3-4 centimeters, and there was galloplymph. So this baby has not improved much, despite boluses of fluid. Further management continued as suspected sepsis, but also due to poor improvement with fluid management, suspected congenital heart disease, and in particular coarctation of the aorta, and this suspicion was made on an E&E. So it was very, very good like diagnostic pathway what to suspect in this baby. So baby commenced on prostin. Prostin was started at let's say usual dose, 10 nanograms per kilogram per minute via peripheral cannula. Started on high flow nasal cannula oxygen. Preductal saturations were 80%, so still low, and there were still problems to measure any postductal saturations. pH in gases was 7.15, lactate was very high, 10, despite fluid boluses. Hospital already was in contact with pediatric cardiology unit, so with us. Prostin was increased to 50 nanograms per kilo per minute, and inotropes, it means adrenaline infusion, was commenced in dose 0.1 microgram per kilo per hour. Baby was intubated, ventilated, and transferred to our PICU at the Freeman Hospital. So what happened next? This is our assessment when patient arrived to pediatric intensive care unit. Preductal oxygen saturations were 60–70%. Postductal saturations were not measurable. Urgent echo performed, which confirmed coarctation of the aorta, and in addition, no patent duct. So it means that this prostin did not do any difference in this child. Duct was closed and did not reopen, and there was coarctation of the aorta. Prostin has been increased because there is always hope that you may reopen this duct. So prostin was increased to 100 nanograms per kilo per minute. Multiple fluid boluses up to 80 milliliters per kilo, which is massive dose for this baby, in total was given to achieve preductal saturations around 80%. So then, review of systems. So how this baby looked like. Baby was intubated with oral tube, was on high ventilation pressures, 26/6, with total volume 7 to 8 milliliters per kilo. There was no respiratory problem. And FiO2 was 100%. Oxygen saturations on arrival 67%, then improved to 80% with fluid boluses. And we achieved on ICU pre and post-ductal oxygen saturations after a while during this review, 85%. High anotropic support. Adrenaline was increased to 0.2 micrograms per kilo per minute. Prostin was 100 nanograms per kilo per minute in aim to open this closed duct. Heart rate 140 beats per minute. Mean blood pressure 60. Difficult IV access. Lost peripheral cannula while having an echo. So another cannulas, peripheral cannulas were inserted, and also one intraosseous needle inserted as emergency. Baby was given boluses of ketamine. Baby passed urine before admission, and there was no urine during this stay on ICU. Bladder was full on ultrasound. Sodium was low, so received hypertonic saline. It was high hemoglobin, normal platelets, and PT25. Baby was on antibiotic already from an E&E, cefotaxime, acyclovir, and amoxicillin, and this antibiotic was continued. Chest was clear, heart sound normal, no obvious murmur. Abdomen was soft, liver was enlarged 3–4 centimeters below rib, mottled and gray peripherally. So it was low cardiac output state. Pupils were not reactive, soft fontanella, not bulging, but not respond to stimulation. Echo on ICU, so transthoracic echocardiogram, confirmed coarctation of the aorta. Closed ducts, so it never was achieved that duct reopened. Impaired left ventricle function. Therefore, because this duct couldn't be open and also because of impaired already left ventricle function, decision was urgently to move this baby to theater for coarctation surgical repair. So in summary, it was neonatal collapse. Baby was 7 days of age. It was suspected GBS sepsis. Finally, also suspicion of congenital heart disease, in particular coarctation of the aorta. In summary, this baby was very sick, on high cardiorespiratory support, collapsed due to congenital heart disease, and required urgent repair as heart unable to perfuse the body, so it means low cardiac output stage due to coarctation of the aorta. Post-op decision was just to go for, because not everything was very clear. This baby went to theater like during first hour being admitted to ICU, and decision was to assess everything, so end organ perfusion, because not everything was very clear post-operatively. So it was decision of our team, consultant intensive care, cardiologist and surgeon. Post-operatively will be able to assess the end organ perfusion. Fortunately, it was very successful operation. I will describe in my presentation about coarctation of the aorta what operation was done. This baby life was saved. There was quite quick recovery, and it was not end organ function like long deterioration. So this baby came back to normal and was discharged from hospital and remains under cardiology follow-up in outpatient clinic. So very successful, very good repair. In regards to COVID-19, our team contacted local hospital for COVID result as handed over by Nectar that swab had been taken from the baby. No result on their system and no documentation that swab had been taken. So it was handover to theater team. Mom was negative for COVID at delivery. So it was another information about. So it was like first information about COVID. And from anesthetist information, because it may give you a clue how urgent was this operation. Baby was inpatient on adrenaline infusion, glucose, milrinone infusion, morphine, and that's it. And also blood was ordered O negative. Samples were sent as soon as central line inserted. And then all full assessment in theater and further management. So it was very, very urgent situation to save life of this baby. So this is an example of coarctation of the aorta, unfortunately, with no duct reopening during management for saving life of this baby. But very good assessment in a local hospital on an E&E suspecting congenital heart disease, and also very good management when on arrival to ICU with decision of urgent repair of coarctation of the aorta. So this is very short, quick presentation, what coarctation of the aorta does mean, what is the anatomy. I would be happy if you could hear. Okay, so it was this video. I think it was nice to have a look at the anatomy. And now I would like to share with you a very short presentation, and then you can ask me questions regarding this patient. So just go through very quick presentation of coarctation of the aorta. So coarctation of the aorta is 5 to 8% of congenital heart disease. The commonest cause of collapse shock in neonates. This is what you always have to remember. This is the most common reason when you think that there is a shock due to sepsis, and it doesn't look like sepsis, no improvement after treatment of sepsis, you must to think about coarctation. First presentation, collapse, as in our child, or neck. Sometimes neck can be first presentation. We had a patient a few years back, baby neonate, operated for neck. And actually, after operation, at some point, baby had an echocardiogram, and this baby had severe coarctation. So after neck had to be recovered, and then to have operation for coarctation of the aorta. So it might happen. It might be first presentation. It's associated with other lesions like ventricular septal defects, sometimes aortic stenosis, and mitral valve abnormalities. Absence femoral pulses. So this is the clue for diagnosis. However, this is in baby before collapsing. When you have got collapsed baby, you could go through this case presentation. It was hard to feel any pulses. But in very well baby, you may not feel pulses at all, and we sometimes have referrals due to somebody cannot feel femoral pulses and want this baby to be assessed. And I think this is quite good referral. This baby should be checked if you cannot feel femoral pulses, and you cannot wait for weeks. It has to be done quickly. Chest X-ray is not diagnostic, however, will exclude respiratory problem, and also there are sometimes respiratory, like increased working of breathing due to pulmonary edema, so is sometimes helpful just to have a look at X-ray, but this is not diagnostic for coarctation. ECG is not diagnostic also, but you have to confirm that there is sinus rhythm. Transthoracic echocardiogram is diagnostic. So this is how we diagnose coarctation of the aorta. Nowadays, if patient is in a stable condition, but not in our presented case because there was no time, if we have more time, surgeon usually request an MRI or CT. We usually do CT angiogram, which is very quick, is 4 or 5 minutes examination, and you can do CT in babies, in neonates, with no general anesthesia. You can just wrap baby and feet and do CT angiogram. So this is very helpful for surgeon just to see proper place, where exactly is this narrowing, how long is this narrowing for surgical repair is just crucial. So this is a specimen. A specimen is very nice to have a look first time, because you can see how thick, how pale in color. So this is very, very thick narrowing in descending aorta. Is just next to ductus arteriosus. But this is why we usually don't balloon coarctation of the aorta in young individuals, and particularly in neonates, because we wouldn't achieve any results because this part is very, very thick. It just has to be cut up, cut down, and bring together to remove this narrowing. And this narrowing might be so narrow as like pinpoint. So this is coarctation of the aorta, which you have got two types of coarctation of the aorta. We say ductal dependent coarctation of the aorta and not duct dependent coarctation of the aorta. So duct dependent is usually neonatal coarctation. When duct closes, there is no systemic blood flow, and it happened in our baby. And you may have adult coarctation of the aorta. Duct closes, coarctation is usually a bit below and is not dependent on duct. There is some narrowing, but this is not so narrow initially that it does allow some blood goes under high pressure down. And in time, these people develop collaterals. So this is completely different hemodynamics of coarctation of the aorta, adult or bigger children coarctation of the aorta. But you have to remember coarctation of the aorta, like in this video, may be diagnosed any time in life. So it's not only neonatal. Neonatal will be dependent usually on duct. This is why after duct closing spontaneously after birth, it may happen like in our case 7 days after birth, but it might happen 2 or 3 weeks after birth. Duct closes and there is almost no flow, systemic blood flow, then this is a reason why this baby collapses. This is this narrowing in echocardiogram. And in color, you can see this narrow part. This is aliasing of color. So this is very easy diagnosis in neonates. And this is CT. So our beautiful, lovely CT just showing where exactly is this narrowing, and surgeon just exactly does know what to do, where to go. And for example, in this case, we had narrowing, discrete coarctation, but you can see also transverse arch was very small. So this is why surgeon wants this information, because this baby did go for coarctation repair, but also hypoplastic transverse arch repair. So it was not only cutting the part of aorta and bringing together, but it was using homograft, we amended whole aortic arch. So this is very important for surgeons. And this is how it does look like in, again, in summary, what investigations we do. We do an echocardiogram, which just shows this narrow part here and aliasing of color. And this is very, very, yeah, so this is this narrow part in echocardiogram. So this is very, very important. You can see here, this is what we can see. So we have to be very careful as cardiologists just to visualize whole arm. Sometimes it's very big. So we have to do echocardiogram. Always very, very careful. And I think that's it. So management, we said in previous presentation, prostaglandin infusion. This is crucial. This is just to keep duct patent or trying to reopen ductal arch. Stabilization usually before surgery, unless indicated differently, like in our presented case. We do surgical repair, end-to-end anastomosis. And sometimes we have to do reoperation because they sometimes have got recoarctation. So how surgeon does this surgery? They usually go through left thoracotomy. So it's from the side of the chest. They go like longitudinal, it means some cut between ribs. And they visualize descending and ascending aorta, and they can see very well this narrow part. They cut below, they cut on the upper side and combine together. So this is the operation. Usually we do end-to-end anastomosis. So this is how it does look like. They cut here, cut down, bring together, and that's it. So sometimes you can see this part may not grow fully, and there is recoarctation, and we have to reoperate sometimes, or in life we have to balloon and put stent. So this is another procedure in life. It's quite common that people with repaired coarctation in neonatal time, they will require something else in their life. So this is the most common repair which I would like you to know. So I think that's it of this presentation of coarctation of the aorta, and I would like to answer questions.
Thank you, Magda. Just going to have a quick look in. Please feel free to post any questions in the chat box, or indeed unmute your mic if you want to have a conversation with Magda. She is here for the next 2 minutes. Nothing as yet. Magda, can you just stop sharing your screen for me?
Yes, of course.
So we can see you fully. Thank you. Any questions from the floor? Oh, there's Magda, can you see those questions in the chat box, Magda?
Oh, thank you for this question. Yeah, I didn't mention about follow-up because it was mainly about case presentation, so how we manage with recent coarctation of the aorta. Patients with coarctation of the aorta have to have long-term follow-up, so actually whole life. First of all, after repair in neonatal period, we have to see usually a few weeks after first operation, then 3 months, 6 months, and every year. Usually we continue follow-up every year. Why? Just to look for results, because it might be some residual problem. So you have to address, discuss anything to, or even sometimes re-repair quickly after operation, but this is not very often. However, in long-term follow-up, we look for recoarctation. We look for any development of arterial hypertension. This is proven and this is known that people with diagnosis of coarctation of the aorta, despite good result of surgical repair, in life may develop arterial hypertension. So sometimes they very early in life, like teenagers or very young adults, they have to take medication for arterial hypertension. So they need regular follow-up. During follow-up, you have to examine patient, you have to listen to the chest, to the heart, but also always look for proper feeling of femoral pulses. And then an ECG, they usually don't have problem, rhythm problems, so this is not usually an issue. But an echocardiogram is done during every follow-up clinic. And also, just in addition to coarctation of the aorta, as I mentioned in my presentation, these people very often have got aortic valve abnormality, so they have got aortic coarctation, but also bicuspid aortic valve very often. So 50% of patients with coarctation of the aorta have got bicuspid aortic valve. So long-term follow-up is not only very often for coarctation of the aorta, but aortic valve abnormality. So this is why they need long-term follow-up, actually whole life.
Thank you, Magda, that's great. So that's taken us just over 1 o'clock. So I'm going to end the session there, and thank you so much to Magda for joining us today for that excellent presentation.
Thank you for having me.
Please feel free to drop us a line and let us know what it is you want next. There's quite a few people across the region asking for things around sort of SVT, and they're sort of more education sessions. But if you've had something challenging in regards to SVT and arrhythmias, we can certainly get Dr. Neil Seller to join us in a session and sort of unpick some of those things if you've had challenging cases. So please feel free to get in touch with us. We're just at the end of the link that Rebecca's posted in the chat, and keep an eye on our website for any future events coming up. Nice to see you all. Enjoy the rest of your day. Take care, and thanks again, Magda.
Thank you. Thank you. Bye.
Bye-bye.